Hi, I'm Lisa Chiu. I worked in the emergency department this summer with Linda Schuler, and our project was titled Continuous Process Improvement, Venous Thromboembolism Prophylaxis, Compliance, and Documentation. Currently, South Point is pursuing certification as a primary stroke center. There are various requirements that go into this certification. Core measures specific to stroke are monitored to determine the quality of care. Stroke Measure 1 addresses VTE prophylaxis. Retrospective audits have demonstrated inconsistent and inadequate documentation of sequential compression devices, also known as SCDs, used for VTE prophylaxis. The first quarter 2011 data for VTE prophylaxis in stroke patients was 76.5% with a target of 100 and a threshold of 85%. So it is evident that there is room for improvement. There have been several attempts to improve this percentage, such as making the components more easily accessible and adding the IPC row to the unlicensed assistive personnel flowsheet. However, the percent of documented use has remained an ongoing issue. This project aims to increase nursing documentation of the use of SCDs for VTE prophylaxis and demonstrate improvement in the Joint Commission Stroke Measure No. 1, Venous Thromboembolism Prophylaxis. Our hypothesis was that education of nursing staff concerning VTE prophylaxis and documentation will help increase the overall percentage and frequency of SCD documentation. Also, focusing on consistent SCD documentation is hypothesized to improve quality of stroke care at South Point. Again, the goal of this project was to demonstrate process improvement. This is done with the purpose of obtaining specialty certification as a primary stroke center. Several steps were taken towards achieving this goal. Chart audits were performed daily prior to staff education intervention to obtain the baseline data. These chart audit forms were designed to obtain information regarding VTE risk level, VTE prophylaxis ordered, and SCD and pharmacologic prophylaxis documentation. Primary focus was put on the frequency and adequacy of SCD documentation on the chart audit forms. To meet the stroke certification measure, the SCDs must be documented on before the end of the day following admission. Next, we had an educational intervention in which posters were developed for the staff and posted in each nursing division. These posters emphasize the importance of VTE prophylaxis and SCD documentation to meet the core measure of stroke. Afterwards, ongoing chart audits were completed for each patient with SCDs orders after the intervention. Finally, comparison and analysis of the data collected before and after the educational intervention was completed. These two graphs show the percentage of SCDs documented on for the first 24 hours after admission and the audit date. The top graph displays the compiled results for the baseline data or the pre-intervention data, and the bottom graph shows the SCDs documented on after the intervention. This table shows the same data but in numerical form. So as you can see, there was an 11% increase for SCDs documented on within 24 hours of admission. However, on the audit date, this dropped 4% after the intervention. We did some statistical analysis on this and found that the increase was actually statistically significant while the decrease was not. This result shows that the education intervention did have a positive impact on SCD documentation. However, there is still room for improvement. The improvement in SCD on documentation percentages observed after the educational intervention was minimal. However, a greater improvement of overall documentation frequency was seen. Many of the SCDs were observed to be documented not applicable, off, or patient refusal instead of on. This demonstrates that the interventions had significant impact on the frequency of documentation, but why didn't the percentages of on SCD documentation increase? It is believed that the lack of patient education for VTE prophylaxis contributes to this compliance issue. Although we observed an increase in documentation of SCD use within 24 hours of admission, the ongoing documentation did not demonstrate that the patients were wearing them more. Many patients complained that the SCDs were uncomfortable or hot and they refused to wear them, but we think if the patients were more educated on the fact of what the SCDs are for and the risks of not wearing them, perhaps the on-documentation of SCDs would improve. During direct observation surveys on the division, we also observed patients wearing the SCDs, but they were not documented to reflect this. This shows an incomplete documentation issue. We recommend that staff education continue stressing the importance of VT prophylaxis and SCD documentation. Also, we should utilize a more interactive education tool, such as a presentation and quiz, to assess the level of learning achieved instead of a more passive form, like the poster we did. Also, continue providing staff with regular feedback to support and sustain improvement. A patient education tool regarding the use and benefits of SCD use should be implemented with the aim of reducing patient refusal SCD documentation and increasing the on. Nurses need to provide ongoing SCD education for the patient and family. Also, involve more of the staff, such as department stroke champions, in chart audits and education process. I would like to thank my mentor, Linda Schuler, my co-coordinators, Linda Pasick and Carol Weber, all the staff at South Point Hospital in the Office of Civic Education Initiatives. I would like to give a special thanks to Nedra Starling and Rosalind Strickland. Thank you.